So today, my talk, I concentrated on three separate kidney conditions that are seen in multiple myeloma. The first one is light chain cast nephropathy. And as I alluded to earlier in the talk, cast nephropathy is a myeloma defining event. And in fact, in 2014, the International Myeloma Working Group specifically defined light chain cast nephropathy as a myeloma defining event, and in fact made it exclusive so that other renal lesions that are commonly seen in multiple myeloma can coexist with multiple myeloma, but they are not myeloma defining events. And what the one thing that we have learned over the years is that serum free light chain is a diagnostic marker for cast nephropathy, so that the risk of cast nephropathy increases as the serum free light chain concentration increases. But there are other things that help predict whether a patient has cast nephropathy or not. The urinary excretion of Benz-Jones protein is also important. Patients that don't excrete Benz-Jones protein have a very low risk of renal failure, while patients that excrete a high level of Benz-Jones protein can have up to 50% risk of developing renal failure. We also can detect this by using urine protein electrophoresis. And if we look at the albumin concentration in the urine, we can determine who are at high risk of developing cast nephropathy. Typically, cast nephropathy patients have low albumin excretion because most of the protein in the urine is made up or composed of Benz-Jones protein. And then finally, the treatment of cast nephropathy is also linked to the serum free light chain. We know now that reduction of the serum free light chain levels is crucial in reversal of the renal failure. You need a minimum of 50% reduction, but not only that, it's the speed at which the reduction occurs that is important. Typically, patients who fail to reduce their protein by day 21 have a much lower risk of recovering their renal function than patients who can reduce their serum free light chain level by day 21. The other kidney diseases that I talked about was monoclonal immunoglobulin deposition disease, or MIDD. And MIDD occurs in about 10 to 15% of patients with active multiple myeloma, but is more often occurring in patients with what we call MGRS, or monoclonal gammopathy of renal significance. These are patients that do not meet criteria for multiple myeloma or lymphoma, but have a B-cell clone that produces a nephrotoxic light chain. And in MIDD, majority of the patients actually have MGRS rather than active myeloma. Now, MIDD, recently, two studies have shown that treatment with anti-myeloma therapy has been very effective in treating MIDD. The most effective treatment is with bortezomib-based therapy. However, any induction therapy followed by stem cell transplantation is also quite effective in achieving complete response in these patients. Two studies have now shown that we require a hematologic response of VGPR or better in order to help the kidney disease. And in patients that achieve a VGPR or better hematologically, they tend to have improvement of their renal function, whereas patients who do not achieve a VGPR will tend to have deteriorating kidney function. Finally, I talked about light chain proximal tubulopathy with or without Fanconi syndrome. This is another disease that occurs in about 20 to 30% of patients with active multiple myeloma, and is characterized by proximal tubule defects such as electrolyte wasting, normal glycemic glycosuria, and aminoaciduria. What's interesting about this disease is that while these patients also respond to chemotherapy from a hematologic standpoint, the renal recovery isn't as well linked to the hematologic response as in MIDD or in cas nephropathy. We don't quite understand why, but we think that these patients tend to have more chronic injury, and so that the injury may not be as reversible. And so the authors of the paper suggest that if we were going to treat these patients, we should treat them earlier rather than later to help preserve more kidney function.